Thank you, Milton, and thank you for this opportunity. This is really exciting. So I'm going to present a concept to you, and we'll see how many people jump on board with it, but I'd love to get your feedback on it. And the concept is that of informed health. So to describe what that is, I'm just going to have you step out of this room and back into your daily lives of how you might have gotten here today. I used 3 of these things on this screen. So what we have in our lives is we have informed lives, and we get the pertinent information pushed to us at the moment of decision making. So it optimizes our choices. We now do this over and over in many aspects of our lives, but unfortunately we don't do that in healthcare yet. So we have informed lives in many aspects, but we don't have informed health yet. So what we're really looking at is a lot of money going into beautiful buildings and lots of wonderful technologies, but we're still far from this ability to have the pertinent information at the moment of decision making to optimize our choice and hopefully optimize the outcome. And I don't mean all the information all the time. It really means tailored, pertinent information, timed at the right moment. And this is true for any stakeholder around the choice, for the patient, the provider, even the payer. So what is informed health? It's a concept that I've been working on for a little while and would love to have your input on it. But to me, it's a fundamental paradigm shift in how we deliver healthcare, how we utilize information. We need to get away from fragmented information and what I call uninformed health, which as soon as you say it, you realize, oh yeah, we all want to get away from that. And we need to get to a multidimensional integrated model. So this is really a mashup of informatics and other health technologies, digital health devices, et cetera. And to get to a coordinated care capability that ranges all the way from low touch to high touch, is very dynamic and responsive to individual needs. And telehealth is critical to this. It's actually the high touch piece of an informed health paradigm. So the power of telehealth, I think, could be better realized if it were put in context of the whole informed health paradigm, and if it were actually purposefully integrated with the other components. And then importantly, I think if the right metrics were applied to telehealth, so you right-size the test of telehealth against what it's really capable of doing in the large tapestry of informed health. So it's not responsible for all the variables of readmission rates. So when it gets tested against things like that, it may not look so great, but I think that we have a way to demonstrate how powerful it really is. We see this happening in other industries. As you know, healthcare is a bit behind in some of the digitization processes that we've seen in other industries. We see informed industries, whether it's manufacturing or energy, et cetera. So we're catching up in a lot of ways. We've also got some very exciting transitions going on in healthcare. I'm not going to read all these to you. I think some of them we're not sure if they're going to stay on the path or not, but some we know we're not going backwards on. I don't think we're going to step back away from value-based care. Team-based care is a priority, and we need tools to support these new concepts or these adaptations that we've all bought into since they were introduced and incentivized. We have data coming in from more sources than we've ever had, and we have new capabilities, but we're not integrating them well at this point. And then new concepts such as precision medicine. Another big thing that we're seeing as a trend is the empowered patient. And this can happen to be a very good thing, but also a very challenging thing. Patients' expectations have risen in some areas. I'm sure if you're practicing, how many are practicing clinicians? Right. Do you feel a sense that patients just want real-time feedback? They want access to you 24/7. They prefer it be convenient for them geographically, et cetera. So these expectations, because they're getting that kind of service in other parts of their lives, that's what they want. So that could be annoying, or we could take that as an opportunity, because that's a very engaged patient. So if we can turn them into an informed patient, we don't have to be giving them all the information all the time. We can guide them to places. We can set up automated processes where they get information that's pertinent to them, and we move them from being an overwhelmed patient to a very excited and engaged patient. But we have to figure out a way to contextualize this information that we're giving them the same way we're struggling with contextualizing information. We have enough evidence that an activated, engaged patient has better outcomes. So we see a lot of things about digitization of healthcare already evident. Obviously, the electronic record, some Practicing clinicians may have mixed feelings about it. It's painful, but we do have more access to information than we've had before. So a lot of these things are great. Privacy security is helping people feel more comfortable about sharing data and integrate it. Outside the hospital, obviously, people like Milton have done tremendous things in terms of extended and remote care. And we've got real-life monitoring. So monitoring people in their real-life settings, or what I call their life flow. So we have a much better understanding of how people are functioning and what loads are placed upon them. We've created new roles in all of this. We also have the device companies stepping up. And the information that was trapped in these machines for years is now being made accessible to us. Not that we have a perfect way of utilizing it all yet, but these are powerful data storage devices that we've just not had access to the information. So that's all coming. We've got a zillion of these things, as you know. And then we've also got hybrids between the consumer wearables and the point of care, or what I call point of life diagnostics. And this is a confusing space because the wearables are not really well validated to medical grade standards, but we're mixing them with some of these devices that are. So it's a confusing space, but great opportunities in that. And then we have all these things coming along the hype cycle. Some are now climbing up the slope of enlightenment, virtual reality, for instance. So we have a lot of new technologies that are moving through this pathway. So basically we have something I call the Panohm. And all the way from the genome, the phenome, the microbiome, all the way back to what I call the phonome, which means we can pull consumer analytics out of our phones now. And if we could actually integrate these data sets and layer them together, we find new relationships that are very powerful. So with all of this going on, we do feel like we're on the front of the wave. However, mostly we feel like this, because we just feel like we're standing in front of this massive wave of data that we actually aren't being able to leverage well. And part of that is because to get that health information really utilized well, we've got to turn that data into actionable information. It's got to be contextualized. It's got to be accessible. Going back to right information, right time, right decision, that requires interoperability and a lot of smart processes. And fortunately, there's work going on in that space. The interoperability gaps are a huge challenge to getting to informed health. The costs of interoperability gaps, everyone identified by the ONC has a B behind it, billions of dollars, whether it's supply chain of pharmaceuticals, et cetera. It doesn't matter, extremely costly, creates redundancies, errors, all these things you know, and it affects every aspect of health and healthcare. So there's some attempts in some of the startups and in the commercial world to address this. They're not enough, but they solve parts of the problem, parts of the journey. And then we've got groups such as UCSF and Cisco partnering to build interoperability platforms. And in addition to the technology, we actually need some frame shifts in how we think about data. This is a brilliant woman, Laura Esserman, a breast cancer surgeon. Some of you may be familiar with her work, but she's been working for years to integrate data in ways that it's usable so that patients enter data one time, but it gets used many times. And it gets managed in the right way so many people could use it. We can actually understand it. She does big trials across the UC system, and now the FDA is using her integrated platforms in their trials as well. So this is a concept that we could start to get our heads around, and I like it because I like to think of a health sphere. I like to put the patient in the middle. I borrowed her diagram and created the patient health sphere because it is how I look at it. Patients touch healthcare data or generate it in many points of their health sphere. The EHR is not the center of their universe. So we have to figure out how we integrate the data that they're touching at all these different places in their health sphere, whether it's their genomic data or they're in a registry or a clinical trial or they're wearing a wearable, for instance, or they've done a PRO and we want to get that data in the EHR, but we also want to intersect it with the rest of their health sphere data. So this is just a good graphic, and Laura is a forward thinker in concepts as well. If we can do this, we can get to this adaptive and learning knowledge network that we're really desperate for, and it's the only way we're going to ever realize precision medicine. So basic clinical, social, and behavioral sciences need to integrate the omics, the digital health, the informatics. And so I think that many of you have probably seen that slide before, but as a real case example, we have a couple of groups on campus who are working towards informed health with some of their projects. MS is a very challenging condition, relapsing, remitting. Anyone in here know people who have MS? Yeah, it's very difficult for the clinician to hear them say, what's going to happen to me? Am I going to get to my son's graduation? I'm going to be able to walk by then, because it's such a variable course. So one thing we've never had is the ability to plot them, even against themselves, but certainly against larger data sets, and to refine it to people who look like them, so apples to apples. Just like we do with pediatrics, put them on a height and weight growth curve. Are they on the curve, off the curve? What'll happen if we do a certain intervention? So here they've taken their research database, which is the richest in the country, and it's genomic, it's imaging, it's functional scores, it's pharmacologic, and only the researchers had access to it. All of that information never entered the conversation between the clinician and the patient before, because there was no way to pull it together and make sense of it. So they've created these beautiful algorithmic ways of producing it in dashboards so patients can actually look at themselves against other comparative models. And this is a very exciting project in the neurosciences group at UCSF. This one you might have heard a little bit about earlier, because I was set up pretty well by the prior speaker. In the ICU, we have a lot of fancy machines. We have labs going on constantly. We have nurses in and out of the room. Patients are reporting their symptoms, or their families are. But the only time that information comes together is in the intern's head for about 5 minutes on rounds. There's no other time all that information intersects in any sort of a structured way. So this is a project with Johns Hopkins and UCSF where they're actually creating integration of those data sets, and they're trying to do early detection on the 6 most unforgivable complications in the ICU. So this is an example of moving towards informed health. Oops. Then, of course, we look at outside platforms as well, trying to build out that care continuum. But what we're also working hard on at UCSF, and thanks to Atu Butte, who's heading this up, is the informatics capabilities. And how do we leverage that data, even if we were to bring it together? How do we manage it? How do we make sense of it? What are the smart processes? And there's a talk on this later. But if we can do that, we can start doing decision support that's real time, not that we went to Hippocrates and looked it up. It actually gets fed to us in the EHR when we put in certain data points, considering this or that, this medication may be of use. So real time, based on the patient's information, and closed loop, meaning that if I got the information as a patient, that my heart rate was such and such, or that my hydration status was such and such, I would also get an evidence-based recommendation on that. So edge analytics or closed-loop processes are becoming more and more capable. And then all of the abilities around risk prediction and modeling and resource allocation, et cetera. I think what's really important about this, though, is thinking about how do we combine our capabilities of passive sensing with our capabilities of the interactive support that's already in some platforms as automated, and then combine that with the high-touch personal interactions that happen episodically with telehealth, so that you get this cohesive, holistic view of the patient. And I think that's really what we can do and extend our expertise with that. So at UCSF, we are very excited about telehealth. We've met with Milton several times. We've got some initiatives we're talking about, and we have, most of our ambulatory clinics have capabilities of that. We have secure platforms that we use, but we're always trying to advance the capabilities there. We have a resource center, and we also have a UCOP, University of California Telehealth Task Force. I think you heard from Karen DiGiorgio yesterday. So there's a lot of activity and enthusiasm for extending this into our patients' lives and meeting them where they want to be met when it's the right occasion. Here's an example of a child on hospice, and rather than her coming into clinic, her doctor meets her in the laptop and she says, I can see you. And so there are these capabilities that we can start putting in place where they really make sense. And then over here, we're actually using in the ICU, the NICU, sometimes we use telehealth to actually bring the grandparents in. So it's not always just bringing a physician in, but we wanted to make sure it intersected with the EHR. Someone talked earlier today, we can't keep building parallel universes. It's going the opposite direction of informed health. So making sure that we have our telehealth programs intersected. And then our campus is now spread out. We have clinical sites at 5 different places in the city, and until they put the zip line in, it takes an hour to get from Parnassus to Mission Bay. So we can't be racing back and forth if they need a certain consult at Mission Bay and we're up at Parnassus. So we're extending this by doing, this is an example of a derm consult down at Mission Bay being done with hardware and software. And so this is a really important capability. We're extending providers within our own campus and using telehealth that way, as well as the traditional models. And when our inpatients are in, they actually can communicate with their physicians through this device as well, which also runs their big interactive media wall, but they can port the physician into the room and have conversations with them when the physician's not actually physically in the building. And so just like Kaiser, this is Bernard Tyson's quote, but it was very exciting. It was at the end of last year. We have tremendous adoption for telehealth. Everywhere we offer it, it's being picked up. So what we need to do is make sure that when we're evaluating telehealth and deciding, is it working, not, is it cost effective, is there an ROI, are we getting good outcomes, right size it within the context of all the other pieces of that journey and that informed health that need to happen. And so that's really what I wanted to say, is that I think telehealth is extremely powerful. There will always be a place for high touch, no matter how much we automate other things. And make sure that you understand where those telehealth visits fit into the adjacencies of the entire support system we're trying to provide patients in a remote manner. And that is the model of informed health. And I really hope that you get the concept of, if you could have access to all your information as a provider or a patient at your fingertips, when you communicate with your patients, you can each have access to that information. Either of you could do it from the palm of your hand, like you're used to booking a restaurant or finding your way across town. And you also now would have no geographic barriers to other types of expertise, and that's a piece that telehealth really lends. Thank you.
Okay. I don't know if I'm on.
You're on.
Okay. I guess I'm on. Thank you for the talk. Really appreciate it. Question, what efforts are you making towards making the technology seamless and the experience more easy for physicians that work at your organization as well as patients? You went over a ton of technology, lots of different platforms, lots of different companies, lots of different applications. Wrapping those all together, you've got people at the end of them that have to use them, experience them, like them, and want to come back to using them. What are you doing in that capacity?
It's a great question. So I head the Health Innovation Technology and Orthopedics Committee, and one of our jobs is to identify the white spaces and see if there's a tech-enabled solution. But we've got a lot of cats to herd in our department, and trying to figure out if they will all agree to the same one, if they'll adopt it. So what I do is the same thing with patient adopting wearables or any technology, is I've figured out that what we need is the right value to nuisance ratio. And I've actually started calling the VEN. The value has to exceed the nuisance. Yeah. Whether you're wearing a device, whether you're working an app, whether you're doing an EHR feature. So we've got to make sure that they have value from it, that they can perceive and it's not way downstream, and that the nuisance of it is low. So one idea, a specific example is Health Loop or some of those other platforms for extended care, and telehealth, making it accessible in their workflow. So within Epic, they can click on an icon that takes them to that platform, or they can actually book the telehealth visit within Epic. They can do their note when it opens up within Epic. So making it fit in their workflow, so it's easy, show them value as soon as possible. So that's what it's a very general concept, but it actually holds up really well.
Yeah, thank you.
There's one more.
That was a very nice talk. Can you tell us about, UCSF has patients with very wide demographics in terms of the health disparities, and how are you addressing the health, sort of making the portals, particularly for those with disparities in terms of hardware, software, and knowledge of healthcare, and sort of any additional tips you can give for us?
I think it's a really great point. I think in all of our innovation in personnel, process, and technology, we should hold ourselves to the standard of not widening the gap, but closing the gap. And so obviously we have Global Health, Center for Vulnerable Populations, so they specifically work on that. But in all of our innovation, we should be thinking that way. So we should be designing things in multiple media. So whether it has to do with certain people can use a smartphone, others use a flip phone, others have no phone. Whatever your solution is, put it in several different media. It could go out as an email, it could go out as a text, an SMS on a flip phone, it could go out as a message to a community healthcare worker who has the device and then meets with the individual. So I think you do have to build in a model that's tiered like that. The other is we talk a lot about health literacy, so making sure in our intake forms we always say, how do you like to receive information, what's your primary language? But the one thing that startled me when I got asked to give a talk in Barcelona on hearing health, we don't ask about hearing. And so there's this amazing thing about hearing that it so blunts their ability to take in information, and a lot of people are vain about it, so they don't wear the hearing aids, and they certainly don't volunteer it when you're in the office. And sometimes it's subtle. You can't pick up on it without directly asking. The other thing, because I do fracture prevention, fall prevention, it is associated with falls, just certain decibels of hearing loss, and it's also, of course, affects the cognition. So if you want to communicate with patients, a very simple thing to talk about is hearing, and I think we need some better screening around that. But to your point, we should be reaching everybody with our innovations. And it might be that it's not just going to be technology, it'll be personnel and process for some groups.
One last question.
Yeah, when I heard the topic, I was thinking about it from a different perspective. You're talking about it from the internal perspective of the hospital. I'm thinking about it from a consumer advocate point of view, and person who sits on nonprofit boards that advocates for frail seniors and seniors that are income challenged. And so one of the things that I've been watching over the last couple of years is ratings for different kinds of operations within hospitals. So in the Bay Area, there's a huge disparity between, if I just go get an MRI for whatever, I can pay $800 in Pleasant Hill, and I can pay $2,500 here in the local area.
Right.
And so it's just all over the place. So I'm thinking about informed from a different perspective, as in how much things cost, how much time things take, and you're talking about the user interface experience really between the doctors, the patients, the internal to the hospital, whereas I just want to know a simple thing of how much something costs and be able to look it up quickly.
Right.
I'm feeling like the hospitals, or there's something that is blocking that, because I know they have the data, the information's there, the insurance companies have it. Why can't, I'm thinking about it from that perspective. Okay. You're thinking about operational.
No, actually, I'm sorry,
maybe
I
it
didn't
doesn't
get it
blend
across.
together.
I started, I'm a patient, I'm a cancer patient. So I started the whole concept as a patient, as a person. I want informed health for myself, my family, et cetera. So I actually come at it from that vantage point. But I know that I've got to facilitate it for my professional role as well. Cost is very important. I almost said it when I showed you Open Table, because they give you dollar signs. Wouldn't that be great if you're booking your study to know how much it costs? There is a group, Castlight, I think it is, that's their main focus. But yes, the transparency of healthcare costs is a big mission, and it has been befuddled for a long time because of various agendas. But I fully support that, and my mission isn't to do informed health just for the provider side. I really came at it as a person first. Thank you for your comment.
Aenor, can I ask you a question? So
No, sorry, time's up.
So you guys have like bunch of different projects. Like for example, we started working with the genetic department many years ago. You have all these different, like did you see any pattern? Is there a certain department that's more successful at adopting telehealth? Is there a pattern how you even go about as a big system? How do you pick and choose which program to support where?
Well, I think what's been helpful is the Telehealth Resource Center that Linda Brannigan came in and organized, because it truly was very hard for people to know what they were and weren't allowed to do with telehealth. I mean, I was in the Prop 1D early trials and pilots, and it was all store and forward, but people were starting to message me in funny ways, and I didn't know if I was allowed to do that or not do that. So just having a resource center and vetted technologies that the university has blessed is very helpful. And now we have enough people, we have a critical mass. It's become a standard of care in certain departments that they can mentor other groups. So I think it's really catching on momentum-wise.
Okay. Great, thank you so much.